I'm Tamar Pincus. I'm a professor of health psychology at Royal Holloway, University of London, and I've been researching pain for over 20 years. And I'm really interested in working with clinicians and with patients to help them understand and manage pain, especially when there is psychology making the management that much more difficult. What I mean by psychology here is the interaction of cognitions, such as beliefs and expectations, with mood states, such as distress, anxiety, fear, and even anger and frustration, all mixing with the sensory information and combining to create the pain experience, and also influencing motivation and behaviour. Penny has had pain for a very long time, and she's finding that it's all getting too much for her to cope with. She lost her husband a couple of years back, her daughters live far away, and nowadays she hardly does any of the things she used to do. She's here to see the GP, although she's doubtful that anybody can help her much.
Good morning, Penny. What can I do for you today?
I don't really know, Doctor. I don't want to waste your time, but this pain just isn't going away.
Can you tell me about the pain?
Well, yes, it's in my knee and in my shoulder, but it's there all the time. It's making me feel really low. Yeah, it's pulling me down.
Yeah. And when you say getting you down, what do you mean by that?
Well, it stopped me from doing a lot of things, really. I used to play golf, and as you know, my husband died 2 years ago, but I carried on playing because I thought it was a good thing to do, you know, a social thing, but I don't want to do that anymore. I played bridge, but I can't concentrate. Okay. No, I've lost interest in everything, and I just can't concentrate.
And it sounds like you're not really motivated to do things, is that right?
No, I've lost interest.
Yeah. Do you get any enjoyment out of things?
No. I used to enjoy reading and watching the television. No, I don't want to do anything now. And it's all because of this pain.
I think Penny's depressed, and I'd like to discuss with her the treatment options for that depression. But I'm not sure whether to bring up antidepressants or whether to focus on talking treatments, which I think might be more appropriate for this lady and perhaps more acceptable to her.
I'm embarrassed because we've agreed that not much more can be done for my pain, and I don't want to waste her time. But I really need help.
Sometimes, especially when pain lasts for a long time and stops people from doing what they want to do, it's very hard to stay positive, and negative feelings set in. In fact, research suggests that the majority of people with chronic pain would describe their mood as low. The evidence from trials using antidepressants with people with chronic pain actually shows that antidepressants alone are not that effective, and many people don't want to take them, and there are side effects, which is why talking therapies are growing. There are many types of talking therapies, and you need to think as a clinician what's available to you and what would be most beneficial for this patient at this time. Another reason why I particularly like the idea of talking therapies is that my research shows again and again that this pain-related distress is actually quite different from clinical depression. With people with clinical depression, you often find that there is a sense of guilt and shame, and that they think that they are unlikable or even unlovable. I don't find that with chronic pain patients. I find helplessness, which is directly about their pain. I find loss about things they can no longer do. I find worry about the future. But I don't find that they don't like themselves or think that they're unlovable. What they don't like is their pain. To me, this suggests that we shouldn't really medicalize this distress or think about it as a clinical or mental problem. It's part of the pain. It's part of coping with the pain. And what we need to do is think of the most effective intervention to make people feel better about themselves, even when we can't actually deal with the pain itself.
So it seems to me from talking to you that, well, I would just wonder if you might be depressed. What do you feel about that?
I'm certainly feeling very low. Yes, I am, yes. But I think that's because of the pain.
Okay, I think you're right that when people have got pain that's as bad as you describe it, that it can affect your mood, it can make you feel down, and then that can make you feel the pain more, make you more aware of the pain and make the pain more distressing to
Yes,
you.
it doesn't go away. No, I feel terrible.
So I think the two are linked, really.
Do you?
Yeah. Does that seem to make sense to you?
I would agree with that, yes.
It's really important that Penny feels that I believe her, that I don't think the pain is all in her mind, that I do believe that the pain is real.
I'm not sure what the doctor means. Is she saying it's all in my mind?
Clinicians often tell me that this is one of the hardest things for them to do. If somebody's walked in presenting with pain, how do you turn around and say, I want to talk to you about psychology?
But are you saying that's all in my mind then?
No, I'm not.
Because to me it's really real, it's really
The
imminent.
pain is absolutely real. And it's understandable that when somebody's got severe pain, that it makes them upset, it makes them feel low.
Well, I'm feeling very low, very low.
So I think if we can deal with your mood and how you feel, I think that will help you feel better, but it will also help the pain.
Do you think so?
Yeah. Is that something that you'd be willing to try?
Well, I'd certainly like to talk to somebody about it. Yes, I would. Yes.
Okay, so we can get on and organise that then.
When I thought about what she said about the link between my mood and my pain, I realised how true it was. I did feel trapped in this vicious circle, just like she said. The pain got me down, and when I was down, I did less, and that affected my mood, and then the pain got worse and worse.
As Penny discovered, there's a strong connection between mood, pain, and behaviour. Being in pain can lead to low mood and often makes people feel tired and listless. This leads to restricting your activities, but when we stop engaging with life, we've got more time to focus on pain, and we also become less fit. So the pain is noticed more, which starts the vicious cycle all over. That particular consultation ended well, and the patient is on her way to having the treatment, or at least the advice that she really needed. But it's not that easy, and you might need to use different explanations for different patients at different times. You'll find your own way in this. What's really important to remember is that you don't want to give complex and long explanations to people who are actually sitting there in pain, because we know it's hard for them to take in, it's hard for them to concentrate. Whatever explanation you choose to use with your patients, try and include the simple message. Pain is in the brain, not the site of pain. And emotions are in the brain as well, and both of them interact and result in the experience the patient has. So you can't duck psychology, patients can't duck psychology, if we want to cope with pain better.